Yeah, good evening, everybody. We have to start this session, updates in glaucoma management. You want to video assistant? Okay. The first talk is about the video assisted course GATT in different situations by Shikha Gupta, and she has to go to Delhi also. That's why, and it's already first topic.
So we're talking about GAT in different situations. So the shift has been there towards the MIGS over the last few years, and when we look at the IRIS registry, we see that trabeculectomy and GDDs, they are being replaced by MIGS, even for the routine cataract surgery patients, and even the non-specialists are performing these surgeries because it is safe, minimally invasive. The conjunctiva and the sclera, they remain naive for the future surgeries, and the bleb-related complications are circumvented. So, but whom to perform, which patients to perform this surgery is important. So patients with glaucoma should have angles amenable to dissection with clear cornea. And the primary dysfunction should be at the level of trabecular meshwork. If you're expecting collector channel dysfunction, then better not to perform this surgery. The patient should not be very high IOP patient. They should be controlled or borderline controlled on medications. We can also do the surgeries in failing or failed trap patients and in primary congenital glaucoma patients. So when we do the surgery, it's important that we shift the patient's head so that nasal angle can be maximally visualized, and shift the microscope also down around 30 degrees so that the better visualization can take place. So this surgery can also be performed in primary congenital glaucomas with hazy cornea once we are clear with the anatomy. And to help us with that, we have published some techniques like external jugular vein compression, where it causes reflux of the blood in the Schlemm's canal and helps us delineate the Schlemm's canal in a better manner. Or we can also use dye-assisted visualization like trypan blue and ICG dye. And when the other end of the suture is retrieved, we can actually go about. So even in these corneas where we previously were doing only combined trap plus trap, we now have resorted to the MIGS surgeries. So in using aqueous angiography, we have seen that the primary congenital glaucoma patients, they have dysfunctional aqueous outflow channels which get recovered using MIGS. These are the normal patients that we see. So this is the aqueous outflow channels in normal cataract patients. So in congenital glaucoma, there is a dysfunction which gets relieved after the surgery. And this is the pre and post. This is a patient, these are pre-patients of all our PCG patients. And there was almost no flow before the surgery. And post-surgery, when we again do an aqueous angiography, we can see increased outflow in the sectors where it was not seen. So the surgery really helps restore the aqueous channels in a timely manner. So other than that, we can also take use of AIOSMT in defining whether with the suture we are going in the right plane. So this is the inverted angstrom sign, where the tip of the A is actually the suture within the Schlemm's canal, which can help us. And we can use ICG dye, external jugular vein, and to delineate the Schlemm's canal in a better way. So we have recently published that GAT can be done as a first-line therapy in primary congenital glaucoma. This is yet to come online, but it's been accepted. So the results are really wonderful if we look at PCG patients, and almost 90% patients, they achieve success at 1 year with this technique. So when we looked at our outcomes, this is a randomized control trial with 180-degree versus 360-degree GAT in primary congenital glaucoma. This has also been recently published in American Journal of Ophthalmology. We found that the 360-degree GAT patients did better than 180 degrees. And in terms of better lowering of IOP, decreased need for surgical intervention, as well as reduced need for medications. So I think that's mine. So 360-degree fared much better than the 180 degrees in primary congenital glaucoma group, and now we are resorting to 360-degree treatment in these patients. So even when we looked at the CDR reversal, we could find that the post-operative reversal was better with the 360-degree group compared to the 180 group, which did not experience reversal with the surgery. So this is one of the optic discs showing reversal post 360-degree GAT. The GAT can also be done in some refractory cases. This is an example in an NVG eye where it was, the IOPs were 30, 38 on maximum medications, and we didn't really want to do TRAB at this stage and wanted to wait after this MIGS can be done. So we attempted the MIGS. So we have had 4 such patients, and the results are really good over the last 1 year. So we tried to break, after intracameral Avastin was given 48 hours before, we did this goniotomy, nasal goniotomy, which resulted in a lot of bleeding, and therefore we used this irrigating cannula, which helped us clear off the blood, and we could actually cannulate the Schlemm's canal and achieve the 360-degree cannulation. And the IOP loading, once we are done with that, it leads to the falling back of the iris automatically, and they have to be given pilocarpine for some time, and then they don't really go back again to form the synechiae. So in this case, 180-degree was done here, and then the surgery was closed. So in angle closure glaucoma also, we have already shown that incisional goniotomy plays a huge role with phacoemulsification in these eyes, in lowering of the IOPs much more than phacoemulsification alone in terms of reduction in the number of medications, as well as a reduction in the mean IOP. So this is a patient where we did only goniotomy in PACG eye, and we can see this is a pre-surgery, and this is post-goniotomy without lens extraction in one of the eyes, and we can see that actually, even with the goniotomy without lens extraction, it leads to an increase in the aqueous outflow channels post-surgery. So even in eyes with post-TRAB where they are needing medications, this surgery can be used as a salvage surgery rather than going for a re-TRAB, and even the needling is not working. So we can extract the lens along with doing a MIGS, and it does show good results. So recently we've also published a case, a series on GAT in advanced pigmentary glaucoma, and we compared these patients with our TRAB patients in advanced pigmentary glaucoma, and we saw that the results were equivalent. So the number of medications that they were on and the IOP was almost similar in the 2 groups. This was a case report which has been recently published in ophthalmology, where we saw that it also helps the GAT surgery. This is a patient with severe KPs and pigments in the AC with pigmentary glaucoma. And this is the first day post-op that the GAT surgery, because we are actually de-roofing the Schlemm's canal, it also helps in the outflux of the pigments through this route and leads to miraculous disappearance of the keratic precipitates. And of course, then it will also help in lowering of the IOP in the post-operative period. This series we have already compiled, that GAT can also be used. I think I can take some more time as we have less speakers. Thank you, sir. So GAT can also be used when we compared with the results in vitrectomized eyes as vis-a-vis glaucoma drainage device. We saw that the results of GAT were almost similar in IOP lowering and number of AGMs, but the complications were severely decreased. And therefore, so this is the IOP at 1 year. In GDD, it was a little higher compared to this group, and the vision was definitely better in the GAT group. So it can be replaced in those cases where the angle is accessible. Again, this is the emulsified oil bubbles pre-operatively. Post-operatively, we can see the incision without now the oil bubbles are there. So 2 factors lead to disappearance of oil. Of course, one is we are doing surgery and we are irrigating the anterior chamber and aspirating the oil bubbles. But also they may be outflowing through the new tract and the Schlemm's canal that we have just created. So this was one case. We don't have enough data on this, but this was a silicone oil-filled eye with very, very high IOP 3 weeks into the surgery, and IOPs were not coming down. So we thought that as a interim measure, maybe we can try this, because since oil was already there, it could have led to failure of any surgery that we planned, and oil was not to be removed by the retinal surgeons at this point of time. So we planned an interim GAT in the meantime, and we could successfully achieve the cannulation and the rupture of the Schlemm's canal in this patient. The only problem was the oil kept on coming from behind, which we had to aspirate and keep aspirating till the end. And even on day 1, some oil bubbles. So we can already see oil bubble starting to come up through the gap there, and we are trying to aspirate the oil bubbles. But the patient did had a satisfactory IOP control, though with medication, and he's doing well. At least he's not on, mannitol and being admitted in the hospital. So even in complicated scenarios, I want to say, where we did not envisage before that we could do this, we can try this surgery in some of our complicated patients. So now these are the Western data that the surgery is effective also in pseudoexfoliation glaucoma, uveitic glaucoma, and steroid-induced glaucoma. So most of us are now doing, it's simple. We just have to take care that the bleeding doesn't occur intraoperatively. We have to close under high pressure, give pilocarpine in the postoperative period, and give him proper positioning so that the bleeding doesn't accumulate in the recently created channel, and the results are wonderful. And of course, they can be upped up with further surgeries if required in future. Thank you very much for patient listening.
Thanks, Shikha, for
nice presentation. Thank you.
Thanks for the very nice presentation. Now we invite Dr. Arup Chakrabarti to talk about cataract surgery in ACG.
Okay. So, a very good afternoon, friends, and thank you, the chairpersons. Thanks, AIS, for the opportunity. See, lens extraction, whether it is cataractus or not, in the presence of angle closure glaucoma, have always been a challenge. I think there is a greater challenge lying in how to deal with the clear lens in the presence of angle closure glaucoma, and that has generated, legal standard generated a lot of discussions. I'm not going into that. I'm talking today about a situation where you have a patient with a visually significant cataract and angle closure glaucoma on multiple medications. So, nothing financial in what I'm going to talk about. So basically, these patients require an additional, a more concerted workup. First, we need to take a call on what type of cataract surgery you're going to perform. At what time would you like to perform the surgery, particularly if the patient is just after an acute episode. Preoperative workup and preparations differ significantly from routine cases. IL-PAR formula also play an important role, particularly if you're dealing with short axial length eyes. Counseling is of paramount importance, and it will become clear as I go on with my presentation. There are intraoperative challenges and issues which are additionally faced here. For example, there will be visibility issues. Cornea may not be very clear, and of course, many of these patients may have a very advanced cataract. Cornea is unhealthy because of previous episodes, acute angular episodes in the past. Pupil again, will be irregular. There may be posterior synechia. AC is usually more often than not is shallow in these situations. Many of these patients have compromised zonular status. Usually they have a hard nucleus, and then at the end of the cataract surgery, what sort of intraocular lens are you going to place? And then post-op IOP management also becomes more intense here, because there are a lot of IOP fluctuation. You need to follow how the IOP has been impacted by the cataract surgery. So all this require a long-term follow-up. Now, I have done a lot of such cases in the last maybe 10 years, where before I embarked on this kind of management, I used to perform a combined surgery, trabeculectomy and cataract surgery together. But then I realized that many of these patients, their logistic issues, patients are very thin, very fragile, very difficult to perform, trabeculectomy in the post-operative follow-up. They're coming from a long distance, they can't come frequently. So I thought I'll just, do only cataract surgery, careful cataract surgery. And I'm going to present one of those cases here. It's an happening case. So otherwise also it will be quite an interesting video. So this lady actually had intumescent, she was operated, she had her glaucoma was managed elsewhere a couple of years back. You can see EAC, PI, both eyes. So she presented to me with an intumescent cataract, and after the first eye was done, second eye, and the complications were exactly similar. So let me show you. Now I had used IV mannitol, a good digital massage. Such patients are always under peribulbar block, and AC was shallow. It was an intumescent cataract. Pressure was in the mid-teens, actually mid-teens, with all this manipulation. She was on 2 anti-glaucoma medications already. So here the surgical challenge. So ideally you would have tried to perform a combined surgery for this case, trab plus phaco. So here, I just decided to cataract surgery. This itself is going to be a challenge. So we always do a 2-step phacoemulsification in these situations. So this first stage is very crucial, because if it runs out to the periphery, then your whole surgical pathway is going to be altered. So it started out with a cystitome. Most of the time it works out, but then I didn't have much purchase on the capsular flap, so I switched over to the ureter forceps. Please remember that whenever you want to form the anterior chamber in these cases, always better to dump the OVD, a dispersive OVD, not in the periphery, not in the center, because if you brew it in the center, the viscosity of the OVD, it takes the flap peripherally, so you lose the battle. So very carefully it was performed, and there was a small pedicle connecting the anterior capsule to the capsular flap to the anterior capsule. So that had to be very carefully removed. Now capsular bag decompression has to be done. Before that, since we had to use the cohesive OVD, we had to evacuate the anterior chamber, otherwise there will be no pressure gradient which will bring the lens matter from the capsular bag out of the anterior chamber. So here, for some reason, the decompression process was not working out as per plan. I used irrigation to start with, then milking technology, massage the anterior capsule from the peripheral area all around, and to bring the flaky lens matter into the center. So idea is to decompress not only the anterior aspect of the capsular bag, but all around, even behind the nucleus. That has to be done. So I thought that I had achieved a good amount of capsular bag decompression at various levels. Then went ahead with my 2-stage rexis. Prior to that, of course, you make a nick with my intraocular micro scissors. So decompression was done for quite some time. Now the anterior capsule was again stained with trypan blue dye. So at the first incision itself, if you see when I gave the relaxing cut here, it ran to the periphery. So there was nothing that could be done to retrieve it. So I decided that I continue with phacoemulsification, though here the option was to do an manual SICS technique. I'm quite competent in doing it for the last 30 years. So here, before I enlarge the capsular opening, see, whenever there's rexis tear running to the periphery, it is important that you don't build up a lot of fluidics, high pressure situation in the capsular bag. So that will definitely end up with a wraparound tear. It will go to the zonules, to the capsular fornix, and go behind. So the lens matter bag was decompressed further by bimanual irrigation aspiration. So I would require a little greater, as I've just mentioned, a larger axis, bigger axis to manipulate the lens matter. Because if it is a small, again, when you perform phacoemulsification, the fluidics, the turbulence, etc., that build up, that again is detrimental to the rexis tear that has happened. So the downside of this strategy is you have too big a capsular opening, and there's one runaway to the periphery, and maybe I'll just finish up in a minute or so. And so the lens matter tends to levitate to the anterior chamber. So you need to always use a good quality dispersive OVD, frequently top of the anterior chamber, and perform phacoemulsification. So as you perform phaco here, I will be starting off with a very high power, higher than what I would have done normally, because I don't want any translational movement for the nucleus. You don't have to perform a cortical cleaving hydrodissection. The nucleus rotates pretty well. So a phaco chop was done, and at the end of the, so this is important. Now my rexis tear has happened superiorly. So I changed my plan from a single piece lens to a 3-piece hydrophobic acrylic lens. Is a sensor lens. So when the leading haptic comes out, the way the hand moves, invariably there is some amount of manipulations that happen superiorly, and here is where the rexis tear is happening. So I have to ensure that the leading haptic goes in front of the capsule. Otherwise, there will be more stress to the capsular bag and chances for enlargement. So leading haptic was now, I thought I had kept it in front of the capsule, but so much of manipulations involved in pronation and supination of your joints. So at one point I was not really sure where the leading haptic landed up. So injected some more OVD, and then I brought it up with the Sensky yoke from the side port into the anterior chamber. The trailing haptic was generally kept by a compression technique. I try not to dial these cases, so you can ensure that the haptics are placed in the sulcus, and that the optic is captured posteriorly. So the optic is locked in place. This is the day one picture, a clear condensation switcher was used, and this is more than the usual SKs that I see in my cases. But anyway, it was a tough case, and first post-op week patient did pretty well. So basically, I would sum up by presenting a few pearls which I've learned over several decades while managing the cases. You should have a definite pre-op strategy and decision tree in your mind, plan A, B, C, so on and so forth. IV mannitol I was not using routinely, but today, earlier I was using it only when the anterior chamber was less than 1.5 millimeter in depth. Today I use it routinely for all angle closure glaucoma. Periorbital anesthesia no longer do topical. Intermittent globe compression as advised by Osher, but I use a digital massage. Adequate size rexis. Cortical cleaving dissection is important, not in this case, but when it is a nuclear cataract, most of this case is a hard cataract, so it is important that you don't have a pupillary snap, so it has to be done carefully. Rexis size also have to be adequately titrated. And I have had cases where the pressure has suddenly gone up intraoperatively. Advanced cataract, I was not sure it's supracortical hemorrhage, but if you have the slightest suspicion that dealing with supracortical hemorrhage, abandon the surgery, close the incision, bring the patient back, do an ultrasound, and wait for a couple of weeks for the blood to get absorbed. Thorough capsular polishing is very important because they have a lot of capsular fibrosis post-operatively. IOL type, again, is a single piece hydrophobic acrylic lens. Role of passband vitrectomy when the intraocular pressure is very high is there. I've done a couple of cases like that. Post-op IOP control is very, very important. Now, this was actually an article which was, I think, published by IGO group, LB Prasad group and IGO, which sort of corroborated whatever my clinical experience had been. That wherever TRAB was also included, they had performed cataract surgery with significant and sustained intraocular pressure control. So phaco alone can be considered as the initial procedure, even in advanced or medical uncontrolled primary angle closure disease eyes. Having cataract before glaucoma, before glaucoma filter surgery, a common procedure. So that is it, friends. So I mean, you can definitely think about just a cataract surgery in many of these tough situations with coexisting angle closure glaucoma. Thank you very much for your attention. Sorry for the extra time that I took, because I heard the previous speaker say that we don't have a full house, full quorum. So I took the liberty. Thank you.
Can I have one question from you? Arup? If some patient is having age of say around 45 or 50 and he is prone for acute angle glaucoma but no lenticular changes, would you prefer iridectomy or will you advise her for phaco and IOL implantation if the patient agrees on your advice?
Sir, it is again a controversial decision, but since you asked my opinion, I would not do a clear lens extraction. Even if it is a patient where, like let's say fellow eye of an eye which has undergone an attack, I just do a PI, observe the patient, and in case the patient has an episode, then I would do a clear lens extraction. But no, but I know some of my friends who may have a different view, but this is what I do for my practice.
Thank you.
How do we know that we have done enough decompression, when we did the first small rexis?
Yeah.
And you did a lot of decompression. Then even after all that, when you cut it again, it's extended. So is there any way to know that?
I think it's a very valid question. In fact, the first eye also had the same problem, that both eyes had symmetrical complication. So I feel that if my primary rexis had been a little larger, it was 2 millimeter, it was quite irregular. The problems of making a larger rexis is it may run to the periphery. Here it was a very shallow anterior chamber. I had given IV mannitol, so some amount of dehydration of the lens had taken place, vitreous had taken place. In spite of that, the space was a major issue, constraint there. So if you have a small rexis, the two things happen. One is when you try to flush out the lens matter, if you just stretch the capsular rexis margin, see normally rexis margin can be stretched by 60% of its periphery, of its circumference. If it is strained by trypan blue, it becomes more fragile. So it tends to, I have had cases where very small rexis have torn the rexis margin just when it's trying to go to the peripheral sides, to decouple the capsule. So yes, you're right. I should have made a larger rexis. In that case, I could have decompressed much more. But I thought I had, decompressed enough. But obviously, it was not enough. So I was not sure whether it was the pressure from the vitreous which was pushing the lens forward, some of the suprachoroidal hemorrhage happened or not, or whether my decompression was an incomplete process. But all is well that ends well. I mean, you may have complications, but you need to know. Don't lose your cool. Don't do anything knee-jerk. So think and do it.
Thank you very much, Arup. Next is the role of target intraocular pressure in management of glaucoma by Dr. Ajay Agarwal. Ajay Agarwal is there? No? Oh, sorry.
So good afternoon, everybody. So I'll be talking about the role of intraocular pressure in the management of glaucoma. This isn't moving. Okay. So as we all know that glaucoma is a chronic progressive optic neuropathy, and reducing intraocular pressure is the only clinically proven way to retard the progression of glaucoma. So before we start therapy, it is important we rule out angle closure disease, perform a detailed ONH and RNFL evaluation. Extremely important is never start therapy based on a single high IOP reading. So if you have pressures 24, 25, don't start with your timolol straight away. Record the CCT values, and as we've been taught right from the beginning, treat the patient and not just the high IOP. So remember that the normal IOP is just a statistical description of 16 plus minus 2 standard deviations, and the American Academy has a definition, the WGA, the EGS, all of them have defined glaucoma. So all of the purpose of the target IOP is just to have just enough IOP which will prevent your further glaucomatous damage. So it is a range of IOP, it is not a single value, and it has to be individualized for every patient. Some people do it for each eye as well, some people do it for the patient as a whole. So you want to maintain a functional vision throughout the patient's lifetime. So it is also known as a safe level of IOP. So your fundamental goal is that you don't want this graph to go down so that your retinal ganglion cell loss is so much that the patient becomes blind. So you want to stabilize things. So there is a lot of evidence from clinical studies like the OHTS, which has shown that at least 20% reduction of IOP from baseline leads to lower glaucoma progression. CIGTS has also said that TRAB versus medication, so both are useful, and when you have achieved a target IOP, the progression of glaucoma is minimized. Similarly, in EMGT, although they did not set any target intraocular pressure, but they've said that for every 1 millimeter drop in IOP, there is a 10% reduction in the risk of glaucoma progression. The advanced glaucoma intervention study also set a target IOP at less than 18 millimeters, and they've also found that it has a good effect and there is minimal visual field progression at such pressures. Although currently we would like to keep the target IOPs much lower in advanced glaucoma cases. So there is staging of the glaucoma right from suspect, mild, moderate, advanced, and an easy way to do it is by the mean deviation less than 6 to 12 and more than 12 millimeters of mercury. So why do we want to establish a target IOP? So that we have functional vision throughout the lifetime of the patient. The second part is very important. There has to be a minimal effect on the quality of the life. You don't want to bombard a patient with lot of anti-glaucoma medications. You set the IOP on initial visit, review it periodically and individualized for every patient. So you need to consider how much is the existing damage based on your assessment of the optic nerve head, your visual field defects, what is the baseline intraocular pressure, other factors like central corneal thickness and ocular and systemic comorbidities. So as a rough guide, usually for cases with advanced glaucoma, less than 12 millimeters would be recommended. So you establish your IOP based on your individual glaucoma assessment, look at the discs, the corresponding visual fields, and if there is already glaucomatous damage, you need to set lower target IOPs. Also, it is important that you appreciate at what intraocular pressures the damage is occurring in a patient, so that if damage is occurring at relatively lower IOPs, you need to decrease the IOP still more. So for tailoring therapy, it is important to look at a number of factors. For example, if you have a patient with ocular hypertension, early glaucoma, limited life expectancy, you may even observe such patients. But for moderate or advanced glaucomas, you would definitely need to have more aggressive therapy. So if the rate of progression is less, you can set higher target IOPs and vice versa. If the patient is younger, considering other factors are the same, your target IOPs will be lower because the patient has a much longer time to live. Then you need to identify other risk factors like family history of blindness from glaucoma, the other eye, high myopias, vascular risk factors, systemic risk factors. So some of these surveys have found, like for example, that African Americans are more prone to damage as compared to Caucasians. CCT is now an established risk factor, so thinner corneas, you need to be more aggressive in your therapy. And pseudo-exfoliation, again it has been found that in pseudo-exfoliation and ocular hypertension, the conversion rates to glaucoma are much high. But at the same time, you need to look at the quality of life issues. And then finally, how to calculate target IOP will be based on your threshold, IOP less than 21, percentage reduction from the baseline, and formula based, which could be JAMPL, CIGTS, and the modified JAMPLs. Then there are the American Academy guidelines, European Society guidelines, more or less the same. So early glaucoma, moderate and advanced glaucoma, the target IOP ranges would be different. NTG, again, the ranges would be different. So you would like to have a combination of drugs to reduce IOP, or doesn't work, for example, not achieved or progression or poor socioeconomic status, you need to consider trabeculectomy. So to summarize, the target IOP range should be dynamic, revisited at every visit and adjusted over the course of treatment. Target IOP must be individualized. You need to look at the efficacy, side effects, cost-benefit analysis, and multiple factors like how much damage has occurred, IOP at which damage is occurring, and other risk factors. So thank you for a patient hearing.
Thank you, Dr. Agarwal. You have nicely covered everything about this target pressure.
Thank you.
Any question from the audience, please?
Suppose sir, a patient is having tension of about 14,
Yeah.
and still his vision is deteriorating.
Okay. So usually if pressures are 14 and the vision is deteriorating, it has to be in the range of 10 to 12 millimeters of mercury, as is most for advanced cases of glaucoma. Although you cannot be below 10 or such, because that won't really help. But then I think surgery would be an option in that case, if your medications, PV pressures are not getting controlled. So usually, if 3 to 4 drugs not controlled, surgery is the only option. Yeah. Thank you.
And target IOP, I think you can keep shifting also depending
Yeah.
on the progression of the
Yes,
disease.
absolutely.
It's not the first IOP
Yeah.
that you decided at the time.
It is
It will
dynamic.
not be the same throughout the
No,
course
no,
of
no.
the
You
treatment.
need to alter
That
it.
is very
Yeah.
important.
Yeah.
Because you can't write on the file, this is the target IOP for this patient.
That is another debate actually. Some
Yes.
people say you need to write the target IOP on the file. Some people say that the patient gets very anxious if you write it down.
Exactly.
So if the IOP is higher, then he'll say, Doctor Sahab, abhi to ye itna, mera itna chahiye, zyada hai.
Exactly.
So that is again a
By the
dilemma.
time they will come inside the room, they will
Yeah.
already having
Yeah.
anxiety that my pressure is 18 today.
Yeah.
It was supposed to be 12.
12, yeah.
So that adds to the
So corneal hysteresis definitely has a role, although CCT के कई सारे nomograms भी आए, but I think उसमें भी there is nothing really which will say कि भाई इतना आप कम कर दोगे तो exact values आ जाएंगे. But corneal hysteresis definitely plays a very important role here in your measurements.
So are you using CCT as a constant
And we do CCT in all our patients.
Nomogram you use for all your patients?
We do
Correcting
in all
that?
the patients, yeah. Thank you.
Thank you, Dr. Arora. Next is Dr. Shweta. Is he here?
Okay. So we have Dr. Sushma Tejwani, high pressure, high stakes.
Yeah, thank you so much, and I'm grateful to AIOS for giving me this opportunity. I'm just going to talk about high pressure, high stakes, and I think all of us tend to keep feeling these, keep facing these kind of situations. The cataract as well as glaucoma. I mean, there's no proceeding for the slides are not moving. Okay, yeah. So we all face this kind of a double trouble where you have high IOP at the time of cataract planning, and we need to understand what to do with that. So glaucoma management is definitely a must along with the cataract surgery, because the optic nerve is at stake. So what does it depend on? Well, we need to keep in mind, slides are not moving. Okay, so it depends on the type of glaucoma, severity of glaucoma, and the angle. So these are the three things we need to keep in mind. Now let us look at what are the considerations. We have to see whether we are dealing with an open angle glaucoma or an angle closure glaucoma, whether the stage is mild, moderate or severe, and we definitely need to look at the angles ourselves, whether it is open or closed on gonioscopy. The cataract surgery has evolved from SICS to femto cataract surgery now, and similar way we have evolved from trabeculectomy to MIGS now. So I will not be speaking of trabeculectomy here, because that is something that we all know and have dealt with, and I'm sure cataract surgeons do not want to do it along with cataract surgery. So we are going to talk about the MIGS, which have high safety profile, minimal disruption of normal anatomy, and ab interno approach. The efficacy is quite moderate, although lower than TRAP, but at least 20% reduction in the intraocular pressure is what you can expect. It is easy to use for patients as well as physicians. So now when we have to look at which patients would require what, one thing is we need to understand there are different types of MIGS. One is the approach to enhance the outflow through the trabecular meshwork through Schlemm's canal, which we will be discussing today. The other approach is to augment uveoscleral pathway by different techniques. And the third one is to suppress the aqueous production by directly ablating the ciliary processes. Well, here we will limit to the angle approach or the trabecular meshwork approach. Now, angle surgery has been very common for children from the ages. In adults, it always have been a little question earlier because we don't have trabecular dysgenesis in adults, so whether it will work. But now we are pretty sure, and the whole world is moving towards mix. Here I'll be limiting myself to these three things which can be easily done along with the cataract surgery. Well, the key indications of mix with cataract surgery are ocular hypertension, where the pressure does not come down with medication and you have to keep patient on multiple medications. Primary open angle glaucoma, where the pressure is more than 28, angles are clearly open, early to moderate glaucoma, and there are established disc and field changes. This is the most common indication for mix. Now, pseudo-exfoliation glaucoma and secondary glaucomas also it can be used in specific situations, but you do need open angles and early to moderate glaucoma. There are certain situations where certain kinds of mix can be used in angle closure glaucoma, provided the angle is not synically closed and it is after PI, again mild to moderate, not in severe situations. So now, important prerequisite for anybody who does mix is that you should be able to do an intraoperative, preoperative and postoperative gonioscopy to decide and follow your patient. There are certain difficulties when we move towards angle surgeries, say from cataract surgeries. There is some learning curve involved because you have to operate under high magnification, you have to work at an angle, your patient's head is in a different angle, microscope is in a different angle, so the ergonomics is little different when you operate than the cataract surgery. And you have to operate with the one hand holding gonioscope because you're looking at the angle, so largely most of the maneuvers involve one hand only. So those are the learning things that we have. For example, this is the change in working position. This is how we operate routinely when we sit for cataract and trab. And when you have to do the tilt for the microscope and the patient, this is how your elbow angle would be. So just notice the angle of my elbow, how much it has to extend when you have to work. Even if you do optimize the position of your ocular and other things, foot switch, table, still your elbow is not that same position as you work with the cataract. So you need to learn in that position. Learn operating in that position. Then the Schlemm's canal, the magnification, you have to use very high because you're going to work on Schlemm's canal on any mix, and the largest diameter, meridional diameter also is less than 200 microns. So you have to be able to see that kind of a small structure, so you will need very high magnification. So generally when we operate phaco, we use 4 to 8x. For these procedures we may have to go to 15 to 18x. So that is the learning curve there, because you need to have a limited field and very stable hand so that you're not, any small movement will get very augmented when you are operating under high magnification. And there are lenses now which can be, self-retaining and you don't have to hold, but most of the lenses you use, one hand is used to hold the lens, so you have to be performing surgery with one hand. You have to use cohesive viscoelastic, you may need assistant to hold, stabilize the eye. And you need to make sure that there is no egress of viscoelastic, there is not much surface bleeding, so as to improve your visualization, because that's the key thing in any mix. Talking about iStent inject, well, this is a smallest implant that we have that can be put on human body, and it's a titanium implant. The outcomes have been reported to be more than 80% with good cumulative survival of say 74%. Now these implants can be done along with the cataract surgery in mild to moderate glaucoma. I'll just take you through the technique. So you need some amount of some gonio lens, and this is the injector. This is to retract the sleeve, and the black button is to push the sleeve. This is a trocar on which these stents are injected, are held. Now after phacoemulsification, once you put the intraocular lens and you put in pilocarpine to constrict the pupil, and now this is the position you are operating. Now you have to tilt the head away from you and the microscope towards you to optimize the position for angle visualization or to do intraoperative gonioscopy. The idea is that your eyes, oculars and the patient's angle has to be in one line so that you can visualize the angle. So once you've shifted to that position, you can even mark on the microscope if you're not sure how much. So this is eye prism SX, so I'm going to focus on the angle. So you can see this is the clear and fast view of the angle. Once you achieve that, you go inside with an injector, retract the sleeve, and as you saw yesterday in the live surgery, you can just press the black button to deliver the eye stent there, and come back. Then the second one has to go at 2 to 3 clock hours position. So you have to be at the trabecular meshwork, just dimple a little and press the button and come out. You can see both the eye stents implanted there. So this is what can be done after cataract surgery. If you put the trypan blue dye, you can even see the veins or outflow channels being prominent there. This is the post-operative picture showing eye stents in the angle in the same patient. That is in the OPD when you are looking at the post-operative gonioscopy, so as to see the position of the implants. Okay. Similarly, another surgery is Kahug dual blade. This is a novel blade which is created to produce the removal of trabecular meshwork. So now we saw a stenting of the angle. Now I'm going to tell you about the stripping of the angle. So you de-roof the Schlemm's canal for 90 to 120 degrees using this specialized blade called Kahug dual blade. So the principle largely for focusing an intraoperative gonioscopy is the same. You can use any of the gonio lenses available. This is the blade that you see. It has a tip with 2 sharp blades so that it cuts the roof of the Schlemm's canal, and a parallel strip you can remove. So once you see the angle, you indent the tip inside the Schlemm's canal and then move horizontally downwards so as to take off that strip. You can see the stripping of the angle happening to this direction. Then I go back to the place where I started and then go do it in the opposite direction so as to de-roof, say 80 to 120 degree of the angle based on how much you have planned for a given patient. You can clearly see that white strip which is the inside of the Schlemm's canal. Then you have to remove the strip of the trabecular meshwork so that it does not go and reattach there. Some kind of bleeding can happen in both eye stent as well as goniotomy. Just remove that, and post-operatively again you can see the cleft in the patient's eye when you examine post-operatively in the OPD. The third thing is the bang, that is a bent angle needle goniectomy. So you can use a 25 gauge needle which you can bend inwards to create a instrument like a KDB. It's a indigenous way of doing it when for patients who cannot afford. So with the needle you do the same thing. You strip the trabecular meshwork in one direction and then in the other direction. The strips that you produce here are not very refined because you are using a needle, not the glide, but it is good enough to create the effect, and you can remove that trabecular meshwork strip. So this is how these angle surgeries are done with the cataract surgery, and they're pretty simple to do, and you hardly spend 3-4 minutes after or 2 minutes extra than the cataract surgery. Post-operative care is more or less similar to the cataract situations. I do use pilocarpine for where I'm stripping the trabecular meshwork, but not for stenting the canal. The ocular antihypertensives are all stopped after the surgery. So after that you see how the pressures are behaving, and if you have to introduce, that can be done based on how the patient's pressures are responding. Follow-up is usually at day 1, 1 week, 1 month, and every 3-4 months, like for any glaucoma patient. Post-operative gonioscopy should be done to visualize the implant or see the cleft so as to understand whether your surgery is working or no. My experience is very little at this moment. In these cases I have done these surgeries, that is 60% of them are open angles and rest are different ones. So the reduction that I have seen is significant, that is in 90% of the cases, almost 15 to 28%, with average pre-operative IOP 17.32 on 2 meds and post-operative IOP 12.48 on 0.48 meds. Follow-up of almost 5 months on an average and 22 months the longest. And the patients that required post-operative medications were largely the patients where I had done in pseudo-exfoliation glaucoma, secondary glaucomas or juvenile glaucomas. So that has been my experience. I would just conclude by saying that the mixed procedure do provide 25 to 30% intraocular pressure reduction with a minimal risk and faster recovery along with the cataract surgery. The flip side is that the angle surgeries may result in a limited IOP lowering. That means you cannot reduce the intraocular pressure below episcleral venous pressure. So in patients where you require pressure in the single digit, you cannot achieve by MIGS alone. You may have to supplement with the drops, or you may have to resort to trabeculectomy. I am not a big fan of goniotomy 360 degree because it does lead to 360 degree fibrosis and scar formation in the Schlemm's canal. However, it is definitely important for severe cases or advanced situations. So these conjunctival sparing surgeries are here to stay. and they're pretty safe. What I would want to say at the end, the choice of patients and appropriate indications are the key to success. So we need to keep in mind that you do it for the right patients. Thank you for your kind attention.
Thank you, Dr. Sushma. It's a nice presentation and a real advancement in the glaucoma surgery.
Thank you, sir.
Any question from the audience, please?
Yes, you can. Yeah. Yes, I have done.
Have you seen some complications in your this thing?
Yeah, the complications that I would have seen mainly, largely are hyphema, which are self-resolving, and it is not very significant that would be visually disturbing. So some patients do have, 1 millimeter, 2 millimeter hyphema, particularly where you are stripping the trabecular meshwork, but it is self-limiting.
Have you done any study in your institute, just cataract removal versus cataract removal with these things that you have done?
Well, not really a comparative study as such, but what I would want to say in that context, I always keep getting this question whether the cataract surgery itself is reducing the pressure or it is the mix. Well, cataract surgery does reduce the pressure for 2 to 3 millimeters in an open angle for a short duration, but not for a longer duration. And pressure reduction would be more in a situation where there is angle closure glaucoma or angle closure situation, which can be little longer lasting. Whereas these patients that we are talking about are largely open angle glaucoma patients, and we do have follow-up of almost 2.5 years now.
Because these have economic implications,
Yeah.
Devices, recently I think the iStent Infinity was also launched.
Yeah.
So they're very expensive.
Yeah.
And many of the patients that come, is it really worthwhile, ask them to pay more and
Not really, sir. We have options for all the patients. You have simple things like bang also, which costs just 20 rupees needle.
bang has a very good applying. I don't know, I would not be very comfortable with the,
It is, I would say, sir, it is something like that. If
the duration of follow-up that you
bang, yeah, bang I started even before doing eye stents and KDB. So it's 2.5 years. Pressure drop is significant. I have got 20 to 25%, and actually my out of my bang patients, only 1 or 2 which required more medication. None of the bang patients I have reoperated for trab yet. I started the mixed surgery by doing bang only initially, so as to learn intraoperative gonioscopy and see how the feel is, and subsequently started on that. So there are options for all socioeconomic status, like how we have premium lenses, simple lenses, I would say. Thank you, sir.
Thank you very much. Dr. Nutan Kumar? No, not available. Shruti Dayal? She will be speaking on dry eyes and glaucoma, a challenge compounded. It's a really, double trouble for the eyes nowadays with the development of glaucoma, medications and dry eye.
Respected sir and dear colleagues, today I am going to discuss on the topic dry eyes and glaucoma, a challenge compounded. We all know that glaucoma is a chronic sight-threatening disease, and early diagnosis, ongoing treatment for long duration, and treatment adherence are critical to slow down the disease progression and prevent blindness. But when it is associated with dry eye disease, it really affects the quality of life. It has been seen that both of them often coexist, maybe because of the age-dependent prevalence. Both of them are more prevalent in older age. Dry eye disease affects about 40 to 59% of glaucoma patients. Both are associated with mood disorders, depression, anxiety, and when they coexist, they are really a public health burden. The patient of glaucoma, when it has dry eye disease, he complains of burning, stinging, pain, irritation, redness, and it impacts the daily activities. There is decrease in visual quality because it generates aberrations and causes irregular astigmatism and worsens the contrast sensitivity. It affects the reliability of perimetry in glaucoma patients. The poor adherence on the anti-glaucoma medication further worsens glaucoma. So early diagnosis and management is very necessary in patients of glaucoma. Ocular surface disease index shows that ocular surface staining was more prevalent in glaucoma patients as compared to controls. Tear breakup time was shorter, Schirmer's scores were lower, tear osmolarity was affected, conjunctival hyperemia, eyelid abnormality, meibomian gland dysfunction, and conjunctival hyperemia has been seen. Many case reports in the OPDs are being found. In each of us OPD, we find that patients on anti-glaucoma medications for a long time, they develop irritation, itching, redness persistently. The meibomian gland disease and dysfunctions are being seen in the patients with glaucoma. Periorbital dermatitis is seen in patients of glaucoma, who are on anti-glaucoma medications. Then back-induced acute allergic reactions and mild chronic blepharitis has also been seen because of long-term anti-glaucoma medications. So why dry eyes occur in patients with glaucoma? It may be because both dry eyes and glaucoma are coexistence because of the age factor. Another, glaucoma medications themselves as well as the preservatives in the glaucoma medications affect the ocular surface. Ocular surgeries also affect and modify the ocular surface responsible for dry eyes. The pathophysiology of dry eye disease in glaucoma is multifactorial. It causes a self-perpetuating vicious cycle caused by risk factors of dry eye disease and glaucoma, which are responsible for a combination of tear film abnormalities and instability, resulting in release of inflammatory cytokines and mediators, altering the quality of tear, reducing the reflex lacrimation, and thus ocular surface drug concentration increases. And this further increases the tear film instability. Anti-glaucoma medications, they have an inflammatory effect on the tear film, reducing the production of tear film. They have effect because of the preservatives and excipients, which will disrupt the corneal epithelium and reduce the corneal sensitivity. The chronic use and the number of daily drops put in the eye every day, they have been shown to be causing goblet cell loss and dysfunction, meibomian gland dysfunction, pseudopemphigoid reactions as well, and cicatricial conjunctival changes. The preservative, especially benzalkonium chloride, is the main culprit, has been found to be added into the preparations because of superior antimicrobial effectiveness, but it negatively affects and impairs the corneal sensitivity. Ocular surgeries also modify the ocular surface, like trabeculectomy has been reported to cause corneal epitheliopathy, filamentary keratitis, and tendon formation. So a patient of glaucoma, if has a pre-existing dry eye disease or develops dry eye disease on anti-glaucoma medications, then should be treated as early as possible. Ocular surface inflammation may manifest as early as 3 months after the initiation of anti-glaucoma therapy. So a detailed medical history of the patient should be taken in order to find out the other risk factors which may be responsible for this. A detailed clinical evaluation of the patient, each and every patient of glaucoma should be done in OPDs, like through tear film assessment by Schirmer's test, tear meniscometry, tear film osmolarity, tear meniscus height. Then fluorescent tear breakup time should be assessed, and it helps in assessing the degree of aqueous deficiency. The non-invasive tear breakup time also through keratograph, placidodisc keratometer has been found to be worse in glaucoma patients. Ocular surface staining helps in grading the degree of dryness in the patient's eye. Then conjunctival hyperemia has been related to number of glaucoma drops put in the eyes. Pseudopemphigoid has been found to be reported in patients under long-term glaucoma medications. Meibography also has been found to be worsened in patients with glaucoma. Metallomatrix metalloproteinase inflammatory biomarker, which is a commercially diagnostic device, has been found to be increased levels in patients who are on back-preserved glaucoma eye drops. So management of dry eyes in glaucoma is a challenge. Long-term treatment plans for both glaucoma and dry eye disease is challenging, and each and every patient should be considered individually. Ocular surface status of each patient should be evaluated regularly as a part of routine follow-up of glaucoma assessment to ensure timely detection and treatment, especially when we start a new topical therapy. The main hallmark of management should be to minimize and modulate ocular surface inflammatory response. So the guiding principles of the treatment will be to minimize the effect of glaucoma therapy on ocular surface and to recognize and treat dry eye disease as early as possible in management course. So we go ahead with either of the options. It depends upon the fact that what is the severity of dry eye disease, what is the stage of glaucoma, and what are the therapies which are available to us. In modification of glaucoma management, we should minimize the use of preserved topical medications, and use of preservative-free anti-glaucoma medication should be encouraged. combination topical anti-glaucoma medicines helps in reducing the number of drops placed in the eye. Switching active component of anti-glaucoma eye drop may be useful as patient may be allergic or sensitive to specific component of the medication. Innovative drug delivery systems are also being made available. Bimatoprost ocular insert, latanoprost eluting contact lenses, latanoprost punctum plugs, they are also being made available. Selective laser trabeculoplasty may be considered more frequently in mild glaucoma patients with similar efficacy and decreased cost than the topical anti-glaucoma medicines. Sustained control of IOP by cataract surgery may be considered in patients with cataract surgery and cataract and glaucoma and dry eye disease. MIGS alone or in conjunction with cataract surgery may help in reducing the reliance on topical anti-glaucoma drops. Role of trabeculectomy is controversial, should be avoided. Then treatment of dry eye disease. Rigorous treatment of ocular surface disease with preservative-free lubricants, especially preservative-free hypotonic formulations of hyaluronic acid, teholose, taurine increase the conjunctival goblet cell density. Ocular surface immunomodulators like cyclosporine, they minimize the long-term chronic changes on the ocular surface. Taurine, an amino acid present in the tear film, it exerts protective role against oxidative changes to ocular surface. Autologous serum 20% helpful in managing toxic epilepsy. Punctum plugs, topical palmitol ethanolamide are other aspects. Then treatment of meibomian gland disease should be considered in patients because 80% of glaucoma patients may develop this. Warm compresses, pulse light therapy, thermal vector pulsations with meibomian gland expression. So the take home message is glaucoma is a chronic sight-threatening disease and it demands lifetime management. So managing coexisting dry eyes and restricting the negative impact of chronic use of topical anti-glaucoma medication on ocular surface homeostasis is essential to get best visual outcomes, quality of life, and patient satisfaction. Thank you.
Any question from the audience, please? Thank you, Dr. Shetty. You have covered really almost all the aspects of dry eye and glaucoma. When I was doing MS, it was hardly a short note on the dry eye, most of the time. We were not reading dry eye at all, and now the dry eye is on the top. And most important part is that whenever we have some case for operation, be it phaco, refractive surgery, glaucoma, we must look for this MGD and dry eye and treat it properly. That is very, very important nowadays. Dr. Madhavi, please. Dr. Jagriti. Most of the audience, they have not come. Maybe they are. I am repeating again from the beginning. Dr. Shweta, is she here? No. Dr. Nutan? No. And Dr. Jagriti is also no. Madhvi is not there. So I think we conclude the session, and if you have any question, you can ask the speakers. Okay, I think we conclude the session.
Thank you so much.
We can have one photograph with the, yeah, please come.